Hello, I am Sunil Agarwal, an interventional cardiologist and chief medical officer at healthsoul.com. I am hoping to generate some very interesting discussion today about the care of patients with heart disease, especially in the time of coronavirus epidemic. I hope to contrast the healthcare systems in India and United States in terms of cardiovascular care when both these countries are at slightly different stages in the pandemic. We have the opportunity to understand more from two very energetic and busy interventional cardiologists about how to take care of yourself and your family member in this time. Dr. Samir Gupta is director of cardiac cath lab at the Metro Hospitals in India. Dr. Ish Singla not only leads the busy cardiology practice for a group of 400 providers in central Illinois, he is also the co-founder and CEO of healthsoul.com. India has reached close to 500,000 tested positive coronavirus cases while ramping up testing capacity and reopening business after lockdown of 8 weeks. Let me start with a basic question of what are the common symptoms of this virus?
Thank you, Dr. Agarwal, and hi, Dr. Singla. I think this
Hi,
is a
sir.
great initiative that you're doing of awareness. And coronavirus, it's really changed everything. It's changed the way we live, changed the way we function, and things now wearing a face shield and wearing a mask, at least in India, as healthcare providers, is the new normal. And the thing with coronavirus is that there are symptoms of the coronavirus, but a majority of people don't really have symptoms. About 80% of people don't really have much in terms of symptoms that we classically see. They have mild symptoms to no symptoms, and usually the symptoms that some of the people have, the most common thing is fever. About close to about 85-90% of people, according to some studies, have fever. Some of the other things are cough, fatigue, shortness of breath. You may feel that you're not able to do things that you previously could. You get short of breath. You may have a cough. You may produce phlegm. Joint pains is something which is very commonly seen with COVID. Some people have a sore throat, headache, just non-specific symptoms. One of the very interesting things with this with COVID, smell, your sense of smell, and you lose your taste. So there are two kind of interesting things that have come up with COVID-19. But one thing to remember is just because you don't have symptoms does not mean you may not be infected or infected.
So I think one has to assume that they have infection unless proven otherwise at a given time. Let me follow up with asking you about, this is mostly a respiratory virus, but it affects heart also. Can you expound on that, of how it affects heart?
Yeah, so this virus is very different from some of the other viruses, the usual respiratory viruses that we see, the RSV virus, or even for that matter, the flu. So some of the things that we're finding with COVID is that yes, it spreads through the respiratory droplets and primarily goes and affects the lungs. But what happens in this case in COVID is that there's a systemic inflammatory response. There's a cytokine surge, and people can get very sick, and they can have multi-organ dysfunction, which includes the heart. And what happens in the heart is the heart strength of the heart goes down. You can have a cardiomyopathy with it. The functioning of the heart goes down. Your heart muscle can go under stress, and we find that there is a lot of troponin elevation, as we call it, which is a marker of muscle damage or stress on the heart muscle. This is not really equivalent to a heart attack per se, but just the stress on the heart. And also, this can, because of the inflammation, like it causes a myocarditis.
Thank you, Dr. Gupta. Let me ask Dr. Singla about some of the medications. As you said, this is a common problem in patients with cardiac diseases. They are concerned about taking some of the commonly prescribed medications for blood pressure, similar to lisinopril or losartan. They are in the category of ACE or ARB inhibitors. Dr. Singla, should patients not take these medications?
Thank you, Dr. Agarwal. So there was some initial data that patients who have high blood pressure and take certain medications like lisinopril, which are ACE inhibitors, that they may have higher risk of infection. But as the more and more data has come in, But one thing we know for sure, the patients with heart disease and high blood pressure are at higher risk of death from COVID. And patients who have treated high blood pressure are at lower risk as compared to patients who are not treated. And the new studies have shown that the patients who take ACE inhibitor or ARB, which are the commonly used medications for blood pressure, they are not at any higher risk than other rest of the people.
What do you think about medications like statin, Lipitor, atorvastatin, which is again very commonly used by patients with heart disease or to prevent heart disease?
So statins are used for cholesterol lowering, but they also have anti-inflammation response. And as Dr. Gupta said, that there is a systemic inflammation in the body during COVID. There was a data published yesterday that patients who are taking statins have a lower mortality as compared to patients who are not on statins. It is just a retrospective study, of course, but this just tells you that they are at least safe and they do not pose any danger.
So I guess our patients should continue to take these medications, both ACE, ARB inhibitors, as well as statin. Let me turn to another serious question about mortality. US has seen more than 100,000 deaths. What is the mortality rate of COVID infection in hospitalized patients with cardiovascular diseases?
So as you said that, patients who have cardiovascular disease or high blood pressure, they are at higher risk for mortality. Patients who don't have any comorbidities or have any heart disease or diabetes and are young, the mortality is less than 1%. Whereas patients who have high blood pressure or those with previous heart attack, the mortality may be 10% and as high as 20% in patients who have congestive heart failure or weak heart muscle.
I would like to add one thing, Dr. Singla, that that yes, cardiovascular mortality, that people who have high blood pressure and diabetes and stuff, they have a higher incidence of death. But what we're also finding, and especially when you look at India and the government released data about a month ago of the first 3,000 deaths, and 50% of these people were more than 65 years of age. And that means that 50% of the people were less than 65 years of age also. And these were the productive people of society. Whether they have heart disease, in a country like India where there is an epidemic of diabetes, epidemic of blood pressure, it's hard pressed for us not to remember that even young people in India are dying, or across the world are dying. And even if they're not dying, they're getting really, really sick.
I agree. There is definitely a good chunk of young people who are getting sick, ending up in the ICU, just like patients who are more than 65.
So I think nobody is protected from COVID despite their younger age. Let me turn to an interesting fact which is covered by a lot of media outlets suggesting that during the COVID, the major heart attack rate or ST elevation MI may have gone down. Dr. Gupta, have you seen lower number of patients with MI during the lockdown period?
Yeah, this is very interesting, and I know I've talked to Dr. Singla and I've talked to some other doctors across the world about this exact same thing, that where do the heart attacks go, where do the strokes go? When we look at our initial 8-week mandatory lockdown, and then Delhi opened very soon, because Delhi is the capital city, that's where I live, and Delhi started a slow phase of opening in the first week of May. The first few days, we hardly saw much in terms of heart attack. I don't think that people were not having heart attacks. I think that they were just scared to go out because of the lockdown and because it was a very strict lockdown that they're employed in India. I think there might have been a small dip in the actual numbers because people were at home, they were eating food, there was no stress, etc., etc. So there might have been a small number, but I think a lot of people just did not show up. And then slowly, as the lockdown progressed, we started seeing a lot of fallout of those people. There were people who were coming in who were having a lot of late complications from heart attacks, things that we had not seen for many years, or we rarely see. Like a myocardial rupture, or you see a VSD. We ended up seeing a few cases of those that we normally don't see. And when you took the history from the family member, that why didn't you come? What took you so long? What was the pain? So they always say that, it was a lockdown. We were concerned. We really didn't, it was difficult for us to come. We thought it's just gas, or, it's acidity, and we'll just take a Mylanta. But yes, the numbers did dip, and we started seeing a lot more complications from heart disease and heart attacks.
And I agree. That's the same thing we have seen in our practice in US, that patients are presenting very late from heart attack. It's not that the heart attack suddenly is eradicated from the world. I think people were scared to come out because of the pandemic, because of the lockdown restrictions. And now, as the US is opening up, the um, patients are coming more and more out, and we are seeing the similar late presentation, what we call for the ST elevation MI or the heart attacks.
So to summarize, there may be a very small dip, but patients had not presented at the time of lockdown, and we are seeing late complications of completed MI or heart attacks now.
Dr. Singla, there was this one study I read from Italy, where they had a very nice graph in which they were showing out of hospital cardiac arrest. And in Italy, during the time of the lockdown and unlock phase, as the corona cases went up, they saw that the number of people presenting with heart attacks started dropping, and the out of hospital cardiac arrests were going up. Now, the same thing they saw in the Kaiser Permanente data in California. And whether that is the out of hospital cardiac arrest is attributable to COVID versus just a heart attack not being treated, that's up for debate. But irrespective, a lot more people were dying at home.
I agree.
One of the patient's concern also has been whether the bypass surgery, heart cath, and pacemaker, they were getting delayed because of the lockdown. What has been your experience at respective countries?
So, to the emergency. So, as a cardiologist, I can tell you that most of the procedures that I perform are, for the most part, emergent. If not, they're urgent, if not absolutely emergent. We were fully functioning during the entire phase of the lockdown. We were treating heart attacks, we were treating heart patients, heart failures, arrhythmias. As they were coming into the hospital, people were getting pacemakers. Some patients who required bypass surgery were getting bypass surgery too. There is a second phase of patients who have elective procedures, procedures that can probably wait for a little while. They're not absolutely emergent. That number is usually not that big. It's a comparatively smaller number. Those were the patients who we kind of delayed also, and then there was a delay from their side also because they were unable to come to the hospital, or they chose not to come to the hospital for those elective procedures.
How was the experience in the United States?
I think I agree. Most of our cardiac procedures are not really elective. They are urgent just because they are being done on patients who have chest pain, are having heart attack, or have rhythm issues. So we have continued functioning for our cardiac patients for most part, just like as it was without lockdown, because we had to provide the care they needed.
During the early scare, some of the reports from China suggested that a lot of patients who even had the big heart attacks or ST elevation MI, they were treated with the clot buster medication rather than taking them to the cath lab as a way to prevent exposure of the healthcare workers. What has been your experience in this regard?
So I think initial data from China had suggested like TPA for busting the clot to treat the heart attack, so that there is less exposure to the healthcare workers and in the cath lab, as compared to if you are taking that patient for the cath lab. In United States, our organization, American College of Cardiology, they never went on that recommendation. They always suggested that we should still do the cardiac cath and what we call primary PCI as the main approach for treating these heart attacks. So in our practice, or and in most of US, the practice did not change in terms of treating the heart attack. Patients who will come in with the ST elevation MI, they will get to the cath lab to open up their blockage and get a balloon and a stent.
Yeah, our experience has been very similar too. That for the most part, we never really So I think we were in India were benefited because we saw the lockdown in middle towards the end of March, and by that time we already had 3 months of data from other countries, and we already had a lot of things, and we were able to learn from them from others. So for us, the way we were treating it in our hospital, and I was in the policy that we made, a STEMI is a STEMI, heart attack is a heart attack. COVID positive, COVID negative doesn't really matter. And at that point, you can't even really delay treatment saying, if somebody's having a STEMI or a heart attack and has an occluded blockage, oh, you may be COVID positive. Let's, let's treat you with some other medicine. We gave PPE. We were able to procure PPE in the hospital. Everybody had the full PPE equipment. We were treating them as COVID positive, but giving them standard of care, angioplasty, stenting, whatever need be.
Thank you. Dr. Singla, what can a cardiologist do to safeguard the health of their patients?
So I think the focus should be on prevention and education. As we know that patients with heart disease are more at risk for dying from COVID. So, you know, as recommended by different societies, WHO, CDC, we should maintain social distancing. We should use face masks. And whenever we go and we should not delay the healthcare we need. We should go and see the doctor, but we should use the face mask. We should use hand sanitizer, hand washing. So I think precautions. As long as we are taking the precautions to avoid getting infection and by COVID, we should continue to take care of ourselves in terms of whatever is needed for the heart.
And regarding use of telehealth, I guess a lot of you might be reaching out to your patients via the portal telehealth. And is it easy for the patients to reach you via telehealth?
Dr. Gupta, what do you?
Yeah, yeah, yeah. So telehealth, it's amazing. I saw this ad once that said, who is responsible for the change of your IT infrastructure in your business? And one was option was the CTO, the other was CEO, and the third was COVID-19. And I think COVID-19 has really changed everything, including the way we interact with patients. I think telehealth is certainly something which is coming up in a big way. It's good for patients, especially if there's a follow-up appointment. Very quickly, we also got on the bandwagon. Telehealth was something that we had talked about in our hospital, but now we have employed telehealth as a facility, as a mainstream facility, which is available for all our doctors, all our patients. We have a big referral base of people who come from all over North India. So now they're able to easily see us on telehealth. We are able to consult them, continue the care that they need. So yes, it has come up to be a really good option for people and a potential game changer.
It's same experience with our practice here. We also went on to the telehealth setup pretty quickly, and most of our providers now are allowing telehealth appointments for follow-ups, especially.
To follow up, the United States has also seen limited staff numbers due to system overload, school closure, and now furloughs and layoffs because the elective procedures were stopped. And the hospitals, they could not make up for the difference. What is being done to reopen and start the healthcare system again in the United States?
So I think the hospitals are taking very systematic approach. They are opening in a very cautious manner. The lot of screening for patients who are going for elective procedures has started. Even COVID-19 testing is being offered to most of the patients who are getting elective procedures to reduce the exposure of their staff and everybody. I think there are certain group of patients who have not seek care and delayed their care, and we should see a demand building up for those in the cath lab, in the other cardiology areas. So I think it's just going to be a slow recovery, but we should start seeing increase in volume for the cardiology patients as the time goes by.
Is there any difference you are instituting, Dr. Gupta, across your healthcare system when you reopen?
So, we Delhi reopened in different phases, pretty much now for the last 6 weeks. And the first week of May is when they started relaxing. The numbers are going up right now. We are peaking as we speak. We are now the epicenter of COVID in the country. We've crossed 70,000 cases, and they're still peaking. And so the numbers are going up, and it's definitely something which is, as a healthcare provider and as a citizen of, as a resident of Delhi, something which is very, you know, concerning of sorts. We as a healthcare institution, what we've done is we do COVID testing on most patients when they come in. When patients are coming into the hospital, and that's what most hospitals are doing now. When they're coming to the hospital, they get a COVID, they get screened. If there is a high risk, they go to a specific part of the hospital where they get COVID testing. If the COVID test is negative, then they are able to go to the routine part where they have to be admitted. And if they are COVID positive, then they go to the COVID positive ward of the hospital. So, I think now as healthcare providers, we are seeing what we feel that is every patient is COVID positive until proven otherwise, because the numbers are just going up. So, we are following all the protocols by the government, social distancing, but, in the hospital, PPE kits, hand washing. Hydroxychloroquine has been a lot of fan following. It's been very popular on social media. The Indian government did actually come out and say in the last update, which was about a month ago, that for prophylaxis in healthcare users, hydroxychloroquine is an option. There have been some small studies done by the Indian government, which have kind of, which have kind of confirmed this. They did this in police personnel and other essential workers, that there was a lesser incidence of COVID-19 in healthcare providers and essential workers who were taking hydroxychloroquine for prophylaxis, or whatever that's worth. So, we've left it in our institution, use of hydroxychloroquine on that particular individual. We've given them all the data, and then if you want to take it, you can take it.
Yeah, I feel myself to be very cautious when we take these findings, because in the time of difficulty and frustration, we want to resort to anything which has the hope for prevention, and we hope that we have vaccine at some point soon. But in terms of treatment, what are the best options available for us to be treating these patients?
So, so I think, as we all agree, prevention is probably the best treatment right now, which include using social distancing, hand washing, PPE, and assuming everybody is positive when they come seek care, unless they are negative, and having a face mask for both for the patient and the physician in an outpatient setting. In terms of treatment, there are a lot of drug options which have been generated a lot of interest. Hydroxychloroquine and azithromycin combination. The antiviral drug remdesivir, that has probably been well studied and used in sick patients who are hospitalized, and has been shown to reduce mortality in those patients. There has been some interest generated with respect to plasma from the recovered COVID patients, and using it as a treatment in hospitalized. Mild symptoms, there are not much oral therapy, except that there are certain amount of data with respect to hydroxychloroquine, whether it is beneficial or not. US government has a different stand on this as compared to Indian government, I believe, when it comes to recommendation on hydroxychloroquine. What do you say, Dr. Gupta?
Yeah, hydroxychloroquine is definitely probably the most popular thing on Twitter and Facebook. If the medicine actually holds true or not. And I think it's too controversial for any of us to recommend it, or to recommend it for anyone. It's definitely not the holy cure.
Yeah. And also, given the side effect and its other uses, I think one has to be extremely cautious with any of the medications which is coming on the horizon without enough data, which has been seen during the time of HIV epidemic when anything and everything was purported as a treatment for both prevention as well as treatment, and most of the therapy didn't pan out in the early days. Um, Regarding steroids, I would say that recent WHO data also suggests that the mortality in very sick patients on ventilators is reduced with the number needed to treat 1 in 8, which is pretty much supportive of our ability to reduce mortality. And that goes with other respiratory viral infections, which have a strong inflammatory cascade as well. With this, I thank you both. I think it was very interesting to hear the perspective from both United States and Indian cardiology physicians. Thank you both for your time. We hope to have similar informational segment with both of you in future.